Hello, and thank you for joining us for this webinar on trauma-informed care in the medical setting. Before we begin, my teammates and I would like to introduce ourselves. My name is Olivia Frank, and I use she, her pronouns.
My name is Ashira Greenberg, and I use she, her pronouns.
My name is Harsimran Sidhu, and I also use she, her pronouns.
My name is Jo Marie de la Pena, and I use she, her pronouns as well.
My name is Victoria Zolfagari, and I use she, her pronouns.
Amazing. Before we begin, we'd like to encourage a few gentle reminders. First off, during the duration of this webinar, please take care of yourselves. Trauma can be an extremely heavy topic to discuss, and particularly as we go into some of the more difficult topics, we invite you to do a body break, take 5 minutes, drink a glass of water, have a snack, and do whatever is required in order for you to get through this webinar while keeping your wellness in as a priority. In addition, we invite you, if you are in a group setting, to share only what you are comfortable with. And lastly, that is the number for the New York City Well line. It includes 24/7 counseling in over 200 languages. Please do not hesitate to reach out if you require any assistance. Again, before we begin, we'd like to create some community agreements in order to have a safe space with which to discuss this trauma-informed care. If you are in a group setting, please remember a 4 walls agreement. That means to take the lessons and not the stories with you when you leave this duration of the webinar. Second, we want to create a safe and non-judgmental space. This means if you are in a position of a group and you will be sharing, please remember to maintain confidentiality and a non-judgmental way of engaging with your peers. Next, please only speak for I. This means that while we all may share experiences, they are also unique and we all have different ways of experiencing things. So please, when sharing stories or when communicating about trauma, speak with your own experiences and your own experiences only. And then lastly, we all come to this webinar with different social, political, religious, and cultural backgrounds, and we ask you to stay open to differing opinions. There is no one size fits all for trauma-informed care.
For today's presentation, we will consist of an overview of trauma and trauma-informed care, as well as prevalence and examples of trauma symptoms. The second section is dedicated to better understanding health outcomes as a result of adverse childhood experiences, and then highlight local statistics particular to the Harlem community. We will then transition to sharing strategies in engaging trauma-informed patient interactions, and lastly, discuss the impacts of stress on providers and how to mitigate secondary trauma through wellness techniques. By the end of this training, participants will be able to describe trauma and trauma symptoms, as well as list 3 benefits of applying trauma-informed care into medical practice, demonstrate effective trauma-informed strategies in patient interactions, and identify at least 1 technique to incorporate wellness into daily routine. To start off this training, we would like to pose this check-in question to you all. In reflecting upon your journey in your career, what has brought you to be a physician? Think about the experiences you have had that led you to where you are today. Feel free to pause this video to take a few moments to think or jot down your thoughts, and press play whenever you are ready to move on. Thank you all for your stories and for sharing a piece of yourselves to us. You might be wondering, why are we asking this particular question when we are here to learn about bettering our practices as physicians? Through this training, our intention is to highlight the humanity within this practice and to remind ourselves of the reasons behind why we are here today, in order to ground ourselves in our purpose. By acknowledging that we are all come from different walks of life, it allows us to open up ourselves to opportunities to help us become better service providers.
Now I will take some time to give a quick overview of trauma in general, some important definitions to know, and go over the data on trauma prevalence, its signs and symptoms. The definition of psychological trauma, as described by SAMHSA, states that psychological trauma is a result of a series of events or a set of circumstances that is experienced by an individual as physically or emotionally harmful or threatening, and that can have everlasting adverse effects on the individual's functioning and physical, social, emotional, or spiritual well-being. Some examples of traumatic events or experiences include witnessing or experiencing domestic violence, sudden or violent loss of a loved one, community or school violence, refugee or war experiences, psychological, physical, or sexual abuse, neglect, natural disasters or terrorism, and serious accidents or life-threatening illnesses. If these events occur in children, you may have heard of them being called as adverse childhood experiences or ACEs. There are many different signs of trauma, and here we have categorized them between changes in cognition, emotions, behaviors, and physical changes. The cognitive changes include difficulty concentrating or paying attention, regression or loss of skills that the child had previously mastered, and poor academic performance. Some emotional changes include feelings of anxiety or being in a state of constant alert, fear, pressure, trouble forming relationships and trusting others. And some behavioral changes include engaging in risky behaviors such as substance use of drugs or alcohol, engaging in sexual activity, being withdrawn or showing avoidance. And lastly, some physical changes that may occur are body aches and pains, incontinence, feelings of a pounding heart, changes in eating habit or loss of appetite, and vomiting. Here, I want to go over some additional signs of trauma that physicians might face in patient interaction. Individuals who have been through trauma may use protective coping mechanisms, which may act as barriers during a patient interview or physical exam. Individuals with an experience of trauma may turn neutral or positive things into negative ones. They may be distrusting of friends and family they were close to before and may not trust healthcare providers. Oftentimes, there is self-blame associated with trauma where good intentions towards oneself are seen as bad. And lastly, individuals with these experiences tend to use defensive language and actions to protect themselves. Now that we have gone over the signs, here is what the prevalence of trauma looks like. The latest data on nationwide prevalence of child abuse and neglect cases averaged to 683,000, or about 9.2 survivors per 1,000 children. More than 2/3 of children reported at least one traumatic event by age 19. The COVID-19 pandemic has only made this situation worse. Over the course of the pandemic, the total number of emergency department visits related to child abuse and neglect decreased, but the percentage of such visits resulting in hospitalization increased compared to the 2019 data. The pandemic has affected healthcare seeking behaviors and patterns for child abuse and neglect, which raises concerns that victims might not be receiving care and that severity of injuries remains stable or worsened. In this slide, the dark blue line in the graph represents data collected in 2020 during the COVID-19 pandemic. On the graph, you can see that soon after the declaration of a national emergency as a result of the pandemic, the proportion of child abuse and neglect visits per 100,000 emergency department visits increased drastically compared to the data collected in 2019 over the same months. Knowing all this, what can you all as physicians do to mitigate the negative effects of trauma and ACEs? That's where the practice of trauma-informed care comes in. Trauma-informed care shifts the focus from asking what is wrong with you to asking what happened to you. The main goals that trauma-informed care seeks to meet are: 1, realize the widespread impact of trauma and understand paths for recovery; 2, recognize the signs and symptoms of trauma in patients, families, and staff; 3, integrate knowledge about trauma into policies, procedures, and practices; and fourthly, actively avoid re-traumatization. And the core principles of trauma-informed care are safety, trustworthiness, and transparency, peer support, collaboration, empowerment, and humility and responsiveness. Now, I invite you all to take 30 seconds to reflect on how you can integrate trauma-informed care into your practice. Please feel free to pause the video and play whenever you are ready to come back. Thank you.
Thank you for that overview of trauma, Simran. I will now be going over the health outcomes of ACEs as well as some statistics specific to the Harlem community. So according to the CDC, certain patient populations might actually be more at risk for ACEs than others. These communities are communities such as those with high rates of violence and crimes, those that have easy access to drugs and alcohol, have high levels of social and environmental disorder, high rates of poverty, as well as high rates of limited educational and economic activity, and unstable housing. In addition to other factors, such as high unemployment rates, factors such as where neighborhoods don't know or they don't look out for each other, and there's low community involvement among the residents, where few community activities are for young people, and where families frequently experience food insecurity. To be clear, however, the risk factors discussed are not specific to certain people and or groups, as there are bigger systemic issues at play that affect these components. The community risk factors can happen to anyone, where certain populations might be more at risk due to systemic issues, and it might just be more apparent in certain neighborhoods than others. Looking at the social ecological model here, one can see how there are actually factors outside of the community that can influence those risk factors, such as national and state policies, as well as within the community, like various forms of discrimination, such as racism and sexism, for example. Populations with high risk factors are more likely to experience the associated consequences of ACEs. ACEs can have lasting negative effects on health, well-being, and opportunity. These experiences can increase the risk of socioeconomic challenges like limited access to healthcare, mental health conditions such as depression, anxiety, risky behaviors such as alcohol and drug misuse, and a wide range of chronic diseases and leading causes of death such as cancer, diabetes, heart disease, and suicide. The cumulative effect of negative health outcomes due to ACEs is that individuals are actually more at risk for early death. Experiencing ACEs as a developing child can lead to disruptions in one's neurodevelopment. These disruptions then affect social, emotional, and cognitive development, which plays a role in the adoption of risky health behaviors. These behaviors lead to an increased risk of disease, disability, and social problems, which puts people at a higher risk of mortality. Taking into account the discussed community risk factors can help explain some of the reasons behind why certain neighborhoods, like Harlem, for example, might have higher rates of ACEs. So within the Harlem community, research has shown that the opioid overdose death rate among East Harlem residents is actually 50% higher than the citywide average. 5% of adults in Central Harlem, which is about 5,500 people, reported experiencing serious emotional distress. Additionally, Central Harlem is one of 4 New York City neighborhoods with the highest firearm deaths and injury rates among youth 15 to 24 years old. The graph on the right shows how children in Harlem are actually nearly twice as likely as other New York City children to be hospitalized due to injuries.
Okay, thank you so much, Victoria, for giving us such a strong sense of the importance of trauma over the course of a lifespan, as well as ACEs and how they impact local communities. As we can see, preventing or mitigating trauma is very important to protect young people from potentially lifelong and life-limiting conditions. So in the next few slides, we're going to review some handy tips and tricks to help you as providers engage with patients in a more trauma-informed manner. So trauma-informed communication is a really important part of trauma-informed care. We would like to point out that trauma should not be approached with a one-size-fits-all perspective. So the categories on this slide and the following slides are not intended to be approached in any particular order. And they really do not reflect a full list of considerations and really should be taken as food for thought. And please feel free to consider them in the way that makes the most sense for you. So the first bucket that we have within this first part of trauma-informed communication is really asking you to consider the person. We know that people can feel lost and object-like within the medical setting, So we encourage that providers should ask patients for their preferred name as well as their pronouns when engaging with patients to help them feel seen more as a full human being rather than just a body. We also would like to draw your attention to the importance of person first language. So an example of that is depicted on the slide, where you really look at a condition that a person comes in with as part of who, as a single part of who that person is rather than the sum total of the person's identity. The next point that we would like to draw your attention to is that communication also occurs non-verbally, so it's important to do your best to remember nonverbal aspects of communication, and that includes eye contact, gestures, tone of voice, body language, physical position in the room, as well as different reactions that you may have to what a patient or their family member is sharing with you. We would also like to point out that different cultures have different expectations with regard to nonverbal communication. So do your best to try to respond to patients in the way that is most respectful for them. Although again, this is not one size fits all, and there is no way to be perfect. So, leave room for self-compassion as well. Next, we would like to ask you to really make space for a person's lived experience. It could be very easy to approach patients with a list like, what's wrong sort of approach, and we would really like for physicians to approach patients with more of a narrative perspective where patients are able to tell their stories. This invites patients to feel more like whole people with complex lives and stories, and may also give you as the provider more information that could help with your diagnostic process. So there you can kind of accomplish two goals with one point. Lastly, to, I guess, sum up the bullet points on this slide, we encourage you to, as best as you can, use framing that avoids judgment. Again, as we said, person first language could be important. We would also like to draw your attention to use phrases like living with versus suffering from. Um, and for the next part of trauma-informed communication, so the first bullet points that we had were really intended to address how you as the provider get information from patients and their families. And then this set of techniques is really intended to reflect how you share information with the patients that you're caring for. So we encourage you to share updates. We know that patients, as I said earlier, can feel lost within the system. So giving people updates can really help them to gain a sense of control over a situation that may feel out of control for them. Everybody is different, of course, but common updates that people tend to appreciate are, a sense of what to expect in the setting with regard to tests, results, and the timing of everything that's going on. Different options of how they can expect their visit and their time within the care setting to progress. Another point that we would like to draw your attention to is to be sure to use visual aids and or translators when necessary. We want to make sure that our communication is being received in the way that we intend for it to be. So we don't want to run into any issues where there's miscommunication because of language barriers or other gaps in understanding. To that end, we invite you to check in regularly with patients, and if there are family members there as well, you can just ask them, did you get what you need from me? What else can I do for you? To just check in with how they're feeling, and also their understanding of the situation. That also ties into teach back techniques that can be used to really ensure that patients are understanding what is being shared with them and asked of them within the medical setting, and to encourage patients to feel like partners in the process, because that really gives that sense of control back to people who are in a vulnerable position of being a patient. You can really frame your teach back as a partnership opportunity where you're saying that you want the patient to explain back what you had just said to make sure that you as the provider did a good job in your job and your role as a care team member. So now we move on to just raising some points about language. We want to be very aware of the language that we're using, because language really does frame our understanding of the world. So we've picked out some examples of ways that people may relate to conditions and ways we might want to reframe that. These examples are just a selection. We've tried to pick examples that can apply to many different conditions, so you can swap out the different diagnoses for whatever is appropriate to your situation. So for example, as I said, with regard to person first language, rather than considering somebody a diabetic, you might want to say a person with diabetes. Instead of referring to somebody as suffering from a condition, you would maybe want to consider saying living with the condition, instead of ex-addict, or again, kind of tying somebody's identity to a condition. You want to say that they are living in whatever their follow-up state is, if that's recovery. And then lastly, we've included a note on suicide, that instead of saying committed suicide, we want to frame it as dying by suicide. And now for this second slide that also reflects language, we tried to kind of take a bit of a broader approach, and look at different concepts that may apply to different conditions, and look at how we frame those concepts. So instead of thinking of medication as a crutch, we want to look at medication and frame medications to patients as treatment tools. We want to talk about things like maintaining recovery rather than staying clean, which could imply something negative about an illness. We want to say, instead of non-compliant, which again assigns a value or an identity to a state of being, we want to say that the person currently does not, because of course compliance can and likely does change over time. And instead of relapse, again, we want to say setback, and give that space for change over time and hopefully improvement as well. And now this slide really gives us a bunch of helpful tips and tricks for a trauma-informed physical exam. As important as communication and language are, we know that the physical exam is a really important and often highly sensitive part of a medical interaction, particularly dependent on the types of trauma that patients may have experienced in their past. So to just go through a bunch of the tips that are listed here, the first is that we want to avoid assumptions. In order to help patients to feel seen and heard within the medical setting, we want to really acknowledge that different people come from different backgrounds and have different preferences and needs. So really make sure as best as you can to respect that individuality by not making assumptions about those, again, needs, preferences, and backgrounds. Identify patient concerns, as we said earlier, take the time that you need to check in with patients, make sure that they're, feeling as clear and okay as possible about whatever is going to happen. And then again, take the time that you need to respond to any concerns that do come up. Do your best to ask about comfort specifically, regardless of whether or not a patient identifies any concerns. Try to see what you can do to make the experience as comfortable as possible. You may want to pay special attention to sharing with a patient what positions or levels of clothing may be needed or not allowed in certain parts of an exam, to ensure that you can ensure patient comfort as maximally as possible. You can also ask a patient what would help them feel as comfortable as possible in a given scenario, whether that's having a support person in the room or breathing exercises or other methods of distraction that may help a patient cope with the physical exam. Obtain consent for each part of the exam. Of course, a critical piece of trauma and trauma-informed care is really giving people back their power and asking for consent in a meaningful way as you go through each part of the process. And again, taking the time to step back when needed, to check in and make sure that you can proceed appropriately. Allow the patient to be clothed to the level of comfort, which ties into what we said before, that certain parts of exams may require that a patient be in a compromised position or not be clothed, and do your best to maintain the patient's preferred standards as much as you can. You can offer to have a patient disrobe one body part at a time and wait for them to reclothe that part of the body before you move on to the next step, if that could help a patient feel more comfortable in the setting. Stay within sight throughout the process. This helps to increase a patient's sense of knowing what's going to happen, that the exam feels less out of control when they see you. It minimizes the opportunity that you will be surprised by anything that is going to take place. Communicate the process. Of course, as we keep saying, it's really important to maintain communication as consistently as you can with patients, checking in at each point to really just make sure that everybody's on the same page with everything that is going to happen. And you just never know where a trauma or a trigger may come up. So the more that you can communicate with a patient throughout the process, the smoother that interaction will likely be. We ask for you to use clear, clinical, non-personal language. You want to really give patients the accurate information in the way that they can best understand, so that they can best advocate for themselves. I would equate this to the way that you might teach a young child anatomically correct terms in a way that's age appropriate to help protect them against abuse, and kind of finding that balance between their level of understanding and also the really accurate forms of information, and trying to strike that balance as best as you can to respect who the patient is as a person with all the context that they bring to the interaction. Check in, as we keep on reiterating and can't be reiterated enough, really just maintaining that constant sense of being in touch with how a patient's feeling. We would like to point out, as we reiterate this over and over again, that check-ins can be light and I don't know that I should say fun, but friendly. They don't need to be these really intense processes, just a good way to really confirm with the patient that things are progressing as they expect and that they feel as comfortable as they can in this scenario. And ask for questions and feedback is always kind of a good way to ensure that you're really inviting the patient to share with you. Patients may not feel as comfortable when you just quickly check in with them. So regardless, you should always invite them to really share any questions and concerns and feedback that they have, and make them feel that those questions, concerns, and feedback are really, really welcome within the space. So now we know that we've shared really a lot of substantive information with you, and we would like to offer, if you would like to take a moment to reflect. Again, trauma-informed care is not a one-size-fits-all process, and so there may be areas in which you feel that you're doing really well and areas that maybe you want to reflect on a little bit more, and we invite you to really take a moment to do that and be kind to yourself in that process. Anything that you're doing is helpful, and thank you very much.
Thank you so much, Ashira, for giving us that handful of tangible strategies to help guide physician-patient interaction. In recognizing trauma's widespread impact and its clinical manifestations, the integration of this knowledge into policy, processes, and practices can contribute to a more trauma-sensitive system that resists traumatization or re-traumatization. But before we start practicing these techniques on our patients, it is necessary for us to check in with ourselves. Trauma-informed care is just as much about physician well-being as it is patient well-being, as they are all interconnected. Now, before we move on to the next slide, we want to think about our discussion we had earlier in the presentation and bring our focus back on ourselves. We want to acknowledge the challenges that the pandemic has brought onto this work, and this past year has been far from easy. Whatever you are feeling now, whatever that may be, if it is overwhelmed, burnt out, or at a loss for words, know that you have every right to feel these emotions in its entirety, because you really are human. I'm not too sure if this is an actual saying, but I want to emphasize the importance of getting through emotion first before going through the motion. One cannot heal or be healthy without acknowledging the hurt that comes with it. It is what you do with that hurt is what influences your ability to navigate past it. At the end of the day, it would be hard for us to teach our patients how to take care of themselves if we as service providers can't do that for ourselves. So to avoid pouring from an empty cup and potentially fostering more harm, we will talk about the impact of stress and trauma on service providers. In this next section, we are going to discuss how that may manifest within providers in response. Medical professionals and non-clinical staff in healthcare are in the position of hearing the recounting of traumatic experiences, thus putting them at risk for experiencing vicarious trauma and secondary trauma. Such prolonged stress or frustration can result in exhaustion, low emotional resources, low motivation, and ultimately making way for impaired decision-making or other conflicts related to patient-helper relationships. Additionally, while the stories of your patients may not reflect your own lived experiences, there is a tendency to take on those experiences as your own. I mean, you're human, of course, and you care for them, but what do we do with that? Research shows that this is especially prevalent among providers during this time. So we want to know what we as providers can do to navigate through these emotions and learn how to better take care of ourselves in order to provide the best care that we can offer. And that first step is recognizing such symptoms when they occur. And those include cognitive symptoms such as intrusive thoughts, flashbacks, impaired memory, disassociation, emotional symptoms such as irritability, helplessness, frequent crying or feeling of numbness, behavioral symptoms such as restlessness, isolation, negative coping mechanisms, or insomnia, as well as physical symptoms such as fatigue, aches and pains, chest tightness, and GI issues. Now, of course, this is not an exhaustive list of such symptoms, so I invite you to think about your day-to-day. In what ways has work-related stress impacted you? If you can reflect upon what that is that triggers these emotions and these responses and observe your body's reactions. And you can feel free to pause this video to take a few moments to think or jot down your thoughts and press play when you are ready to move forward. Thank you again for sharing all of your experiences. And as you may have noticed, that this slide is similar to the slide highlighting the clinical manifestations of trauma among our patients. Here, we really wanted to emphasize the duality of how patients and providers are all interconnected within these collective experiences. Again, we are humans and our bodies react in the ways that humans do. In engaging with trauma through our work or in our personal lives, we further cultivate a sense of awareness, acknowledging that the need to take care of ourselves while also taking care of others to avoid internalizing our others' struggles as our own. And with that, I'll go ahead and pass it back to Olivia to engage us in inspiring ways in which providers can manage their own stress within the work environment through wellness techniques.
Thanks so much, Jo Marie. That was a really great introduction into physician wellness. As medical professionals, especially in a pandemic, words like self-care can probably trigger some eye rolls. So we're going to try to find concrete, tangible, and realistic ways to incorporate wellness into even the busiest 24-hour shift. Because as Jo Marie really eloquently stated, you can't pour from an empty cup. And by cultivating wellness amongst yourself and passing that self-compassion and empathy towards your own experiences and your own well-being, it may actually benefit you as a physician or a medical care provider and benefit your patients in the long run. So some examples of this could be finding sustainable and nutrient-dense snacks for those quick breaks on shift, rather than eating a bag of chips, maybe going for something that has some nutrients and can really help you stay on your feet. using your time and day off to really, or days off, to really rebalance, whether that be connecting with friends and family, disconnecting from the news, refueling, catching up on sleep, all of those really seemingly small things that can help us go back into the workplace feeling refueled rather than burnt out. Also, we'd like to highlight the importance of support. So whether that be your friends and family, your significant other, a pet, or professional counseling, which we're going to talk a lot about, but really destigmatizing the idea of professional counseling and seeking care as a care provider. All of those sources of support can be really, really critical in mitigating some of the negative effects of the trauma that you experience as first responders. And lastly, as Jo Marie already briefly touched on, the importance of knowing yourself. So understanding what are your triggers and what particular experiences you bring into work that may create challenges for you. The more that you know about them and the more you understand them, the more you're able to see triggers and see potentially challenging situations before they occur and bolster your wellness before you go into them. So we'd also like to highlight some national and local community resources. These are both specific to the COVID-19 pandemic and broader. The first is the free lunch delivery service program that's available with Sweet Green Outpost, which is a restaurant in downtown New York that is providing free salads to anyone who's currently working at a hospital. There are also some really incredible programs that provide first responder peer support. They pair you with a first responder who's either at your level or who is more senior, and that sharing of tips and tricks and sharing of what works and what doesn't work and what can you gain from learning from your peers is really, really critical. And that service there, Peer RX Med, creates a really great free professional check-in service. On the bottom left, you also see mental health counseling. Again, I want to reiterate the importance of seeking care if that feels like something that may benefit you. Oftentimes, as healthcare providers, it can be challenging to recognize when you actually need to seek care yourself. And we want this webinar to maybe start to break down some of the barriers and stigma felt in the first responder community when it comes to addressing and accessing mental health care yourselves. As Jo Marie and many of my friends have already said, this is a pandemic and this is a really challenging time to be a healthcare provider. And there is absolutely no shame, nor should there be feelings of embarrassment or inadequacy when reaching out to healthcare services. So we've highlighted a couple at the bottom of the page, including therapyaid.org that offers free or low cost one-on-one short-term professional therapy or counseling. And there are also resources, 3 on the bottom right-hand side, that are New York specific that offer other resources, be there mental health care or physical health care, or support groups as well. Now, we are nearing the end of the webinar, and we would like you to reflect on a final kind of overarching learning response from the webinar. Based on today's presentation, we'd like you to think about one trauma-informed practice that you hope to incorporate into your residency or your medical practice, and one wellness tool or resource that you think you might be able to try this month. One of the important things about trauma-informed care that we've already talked about is being compassionate towards yourself. And there's no need to incorporate every single resource or learn every single tip and trick that Ashira mentioned. It's about stepped care and slowly trying to integrate and learn and better our service by thinking about what might be reasonable to start with. So we encourage you to pause the webinar here and take some time to jot down trauma-informed practices you can incorporate and some wellness tools or resources you would like to try, and come back when you are finished. Amazing. Thank you so much for coming back. We would like to briefly end this webinar by talking about some of the educational materials that accompany the webinar, and they are available for free at Trauma Free NYC's website. And they include an educational poster for medical communities and a Train the Trainer curriculum and facilitator guide that can help you or community members give a type of presentation like the one that you watched today. So we're going to quickly go through those. First, on the right-hand side, you can see the educational poster for medical communities that we created to accompany this information. It includes a brief overview of trauma-informed care, 3 key resources for medical professionals that are both local to New York and accessible nationally, and 7 tips and tricks for implementing trauma-informed care in your practice. This is a really great resource that can be printed as a poster or distributed as a PDF online to help incorporate trauma-informed care into your medical practice and help access this information without having to memorize it. Lastly, we have created a Train the Trainer curriculum and a facilitator guide that can help with in-depth guides for facilitating a similar presentation on trauma-informed care. It includes speaker notes and access to the slide deck that you just watched that can be customized to different communities based on need. Lastly, I would like to take the time on behalf of my team and I to acknowledge some of the individuals without whom this webinar would not be possible. Dr. Rao, Dr. Allwood, Dr. Casau, Sarah Yanissi, and Kirsten Anderson were all extremely instrumental in the creation of this webinar and do really incredible advocacy work in trauma as well. We want to thank you so much for listening to this webinar. If you have any questions or would like more information, please do not hesitate to reach out at the Trauma Free NYC website below. And thank you for participating.